There is another antiviral medication that is not expected to be as effective as remdesivir, but certainly promising and might have a place in therapy. And so we're awaiting clinical trials for that.
Recently, starting from May 2020, a lot of studies have been authorized by our authorities.
The use of therapeutics, largely we took an early stance that if we do, it's part of a clinical trial, if we're uncertain of the evidence behind this particular therapeutics.
We have therefore made the assessment that COVID-19 can be characterized as a pandemic.
As of today, there is no cure or vaccine for COVID-19. After interviewing pharmacists from around the world, we learned about the different pharmacological therapies being used and investigated. As the global scientific community learns more about the virus, approaches to patient care are evolving. In this episode, the pharmacists will explain the pharmacotherapy used in their respective countries. They will also discuss any therapies or vaccines currently being investigated.
We've seen a lot of, a lot of talk, especially early on, about the potential for chloroquine and hydroxychloroquine, and as research sort of caught up with that that use, we've seen that maybe there wasn't any benefit and more potential for harm. So, but I think we're now reaching a place where we've seen some good studies, particularly in the UK, on the use of dexamethasone, particularly in patients that are maybe more severely ill, and dexamethasone has shown some strong potential in helping to reduce death, which is great for people that are especially on ventilation departments. Generally speaking, in the community, quite often it's what we're seeing is maybe there's some antibiotic use to be able to prevent secondary bacterial infections, and more along the lines of respiratory therapies, whether it be inhalers or otherwise. We've seen prednisone regularly. It'll be interesting to see if in the community we see a switch to dexamethasone instead of prednisone. There's also been other everything from zinc and vitamin C and other therapies have been brought up, and I've seen in protocol sheets from hospitals. What the main focus right now is the prevention strategies, and I think that's where testing modalities are going to come into play. And I think they're looking at there's testing to identify people with current disease, the swab test that we currently have, but I think also as we look at serological tests that'll be able to tell if anybody has antibodies, that's going to give us a real good indicator as to how prevalent COVID has been, and what we could then forecast as people that we need to protect.
At this current moment in time, which is sort of late June 2020, really the focus, I think they're still enrolling patients in clinical trials to be treated with remdesivir, which is by Gilead. And that is probably the only real treatment medication that we're using at the moment on a regular basis. Now, there is a study that is coming out that shows some promise with dexamethasone in the most critically ill patients. But I would say more to follow on that topic, because I don't think that the full study has been released yet to allow for appropriate critical appraisal of the information that's presented. Early on, hydroxychloroquine, of course, was touted as a potential treatment, but certainly has fallen out of favor. And the other thing is looking at, so that's for treatment options. We're also looking at, managing symptoms. And so there's certainly a number of medications we use for that. The one that has the largest impact on hospital pharmacists would be using salbutamol inhalers, so salbutamol MDIs. Generally speaking, the mainstay of this type of treatment in a hospital with salbutamol is using a nebulized solution. just because it tends to be easier for patients to manage. But certainly because of the risk of aerosolization of the virus, we're using MDIs. We're preferentially using MDIs over the nebulized solution of salbutamol. So that has an impact in terms of the drug supply. But certainly in terms of actual treatment, remdesivir, I would say, is really the mainstay of treatment at the moment, but only within clinical trials here in Canada. It is not available to purchase sort of exceptionally other than through the clinical trial, which is managed in a different way. There is another medication that they're awaiting a second wave for, potentially to have enough patients to enroll in a trial. And it's with Dr. Alison McGeer. It's not expected to be as effective as remdesivir, but certainly promising and might have a place in therapy. And so we're awaiting clinical trials for that. For vaccines, lots of work on vaccine development here in Canada. I think some of the labs here have some potential molecules that look promising as well. But as with everything, of course, we're months out, if not a year out or more, from a potential vaccine that can be rolled out to the population as a whole. But there is vaccine development here. And those are probably the main things that we're looking at in terms of treatment here in Canada.
Just in speaking to other people in the profession and physicians, really there is, as you know, there's no cure, and there was a lot of talk around hydroxychloroquine and dexamethasone. I think the evidence now for hydroxychloroquine is indicating that it's actually more harmful than beneficial. So they've done almost a complete 180 on that. Dexamethasone seems to have some symptomatic improvement in patients that are admitted to hospital, and reducing some of the the symptoms and the other morbidities that can potentially happen, like the sequelae. So those are the ones that I'm aware of, but really for the majority of patients that are managed on an outpatient basis, ambulatory patients, it's really just supportive treatment, symptomatic treatment with staying hydrated, resting, and things like that. I think we're in an unprecedented time where you have so many scientists and researchers working on a cure, a vaccine, some kind of, or even screening methods. So I think what you'll see is, a combination of things. I think the number one focus right now is the vaccine, and it sounds like it's probably at least a year away. So in the meantime, I think, what needs to happen from, a healthcare perspective is that we need to be very diligent with screening as much as possible, so that there's the most basic form of screening by assessing people's risk factors, their symptoms, do you have any symptoms of COVID that are consistent with COVID? Or what I want to emphasize the most is that we have to keep it simple and remember the most basic and fundamental things of washing your hands, not touching your hands to your face, using sanitizer, wearing a mask, and staying away from the vulnerable population. If majority of people do that, and then you add on the additional things of contact tracing and eventually immunizations, and I think, hopefully this pandemic will be something that we can be, done with in the future.
I think we test almost everything every day, every 7 days, every week. You read about a new Saint Graal, if I can say it. It could be vitamin C, it could be hydrochloroquine, it could be an antibody. And every day it seems that, okay, we have a cure. Today, this is the very time we have a cure. Don't worry, everything will be all right. So we tested a lot of compoundings or molecules. Some of them have already been abandoned because for very inefficacy. Okay, we tested obviously hydroxychloroquine, and we passed through the Lancet problem of being published first, then retired, and then republished. So we had a shortage in plaquenil hydroxychloroquine, and the other countries came after saying, okay, vitamin C, it's useless. There was an antibody, I don't remember, the Avigan, it's useless. In Japan, they already started and saw that it wasn't there was no efficacy. So we really tried everything. We keep trying, we keep testing heparin, cortisone, but we tested many molecules that other countries never even start a trial. As far as I know, we are trying some tests are currently being investigated, but I'm not aware we are investigating on vaccines. We are more focused on some therapies, hydroxychloroquine, obviously, and cortisone, and the heparin. Recently, starting from May 2020, a lot of studies have been authorized by our authorities for heparin. But as I said, I'm not aware of any vaccine in Italy on Italy ground have been authorized or being currently tested.
So luckily, I haven't actually had to treat anybody at either of my stores that I'm aware of. Early on there was, a run on hydroxychloroquine, but most of the treatment is happening at the hospital level. Remdesivir is, I think, really the treatment of choice at this point if the hospital system does have access to it. I also believe that they're working with a lot of dexamethasone for some of the symptoms. I am working with the state and local health departments to try and figure out what the vaccine protocol will be, and how that's going to roll out. It's going to be a huge impact. It's going to be, it's going to be a lot. Curious as to see what's coming down. I understand that the vaccines that are on the horizon, at least one of them is a 2-series shot. So, if somebody's going to come in, they're going to get their initial vaccine, and then we'll have to do a follow-up. And so making sure that everybody's getting the full course, that we can have enough allocated. If we give them their first shot, we need to be sure that we're going to have enough to give them their second. So having to figure out the protocols for that and what sort of a database we're going to be able to work with the state for reporting is going to be our next big program we're working on.
So I think the challenge in the setting of a pandemic, which we haven't had truly for many years, right, is how to be able to disseminate evidence quickly and to be able to treat patients and to optimize their outcomes when it's truly a very serious disease that we didn't really know how to manage in the past. So many therapies came to light with some potential benefits, but then studies were controversial. So we all heard about the impact of potentially using hydroxychloroquine as an example. Some studies were showing benefit, whereas others showed that there was no benefit. And then there were manuscripts that were recalled and what have you. And I think that really tells a story to us as clinicians that often we are faced with problems that we don't have evidence and we don't know how to handle the situation. And we have to use our clinical judgment and to be able to utilize our knowledge of basic science and foundational science to be able to make decisions. And maybe that those decisions didn't turn out to have the best outcomes, but then we reassess as evidence comes in. And so, I think what we were seeing is that people were trying whatever they could, right, to try to improve the outcomes for patients. And then as the evidence started to accumulate, then we were able to better position ourselves to put out guidelines or to put out a perspective to say this is how you should treat patients. So as far as I know, most of the care is supportive. So, we're trying to support people's breathing, using prone positions, even the use of ventilators right now may be of question. And then, the use of therapeutics, largely we took an early stance that if we do, it's part of a clinical trial, if we're uncertain of the evidence behind this particular therapeutic. So we did quickly initiate clinical trials at our institution to be able to study the impact of the therapeutic that we were doing in an unbiased fashion, if you will, controlling for all of the potential confounding factors. I'm familiar with a certain scope of medication. So I reviewed the impact of kidney disease and acute kidney injury and the need for dialysis on patients with coronavirus and receiving different therapeutics. So I've looked at antiviral agents like remdesivir, hydroxychloroquine as an example, and several others. And it appears that, we're still in the clinical trials evaluating the impact of remdesivir, and there may be a population of patients that can benefit from it. Still not 100% certain about all of the outcomes yet from all those trials. But I'm hopeful that the vaccine trials will yield some positive results. There may be subpopulations of patients who have coronavirus that benefit from some therapeutics than others. And I think another important point to note is that the syndrome around this infection is varied, right? Like different people experience different complications around the infection, hypercoagulability versus kidney injury, versus just the respiratory damage that ensues from the virus. So I think there is some heterogeneity in the syndrome around coronavirus infection.
So in the hospital, we've got a few trials running, which are some of which have been very successful and some not so successful. So the main one we've got in secondary care, which is a hospital setting, is something called the recovery trial, which is has got multiple arms, and the number of arms of the trial has increased throughout the sort of the COVID pandemic, when we've been learning a bit more about what may or may not be effective. So in that, we've seen some evidence that dexamethasone is a very effective treatment in terms of reducing mortality in those, particularly with a high oxygen requirement or needing ventilation. Other areas of that trial have been hydroxychloroquine, which you've probably seen, particularly in the States. There's been a lot of interest in that. Our impression at the moment is that it's not of any benefit, but there is some debate as to how that data is interpreted, and I believe the arm of the trial is still open, but my suspicion is that that won't last forever. I don't think that's had the expected benefit that they thought it would. It's quite a toxic drug, particularly at the doses they were trying to use. Another option which has been approved in the UK, which was part of another trial called REMAP-CAP. So it's sort of, it's an intensive care trial. So it's only for those patients who are going for intensive care level treatment. And that is a drug called remdesivir, which is an antiviral, which had some evidence, I think, that was built on from when the Ebola virus came out a few years ago. It was thought to be effective then, and that's where that's come from now. And there's various other arms. So there's some around using azithromycin, so antibiotic principally, but being used for its anti-inflammatory benefits. In terms of actual treatment, it's obviously ventilatory support and medication to support the organ systems. And you may or may not have heard, there's been a lot of issues with clotting in these patients. So for whatever reason, whether it's possibly related to inflammation of blood vessels, we're getting a lot more sort of microvascular clots in the lungs that sort of are disseminated and spread throughout multiple arteries in the lungs, which we think may be contributing to the mortality with COVID compared to other viruses, and also the need for that sort of oxygen requirement and that ventilatory support. So another thing we've done in our local hospital is use a lot more high intensity anticoagulation of our patients. Most hospital patients in general will receive anticoagulation because they're less mobile than they are at home. So they'll be risk assessed, and the majority of patients receive a daily injection of a drug called enoxaparin to prevent blood clots. Generally, for our intensive care COVID patients and some of our higher risk ward-based COVID patients, we've actually been giving them double the doses we would normally on the wards, because we found, particularly in the early stages, that on normal treatment, they were developing blood clots anyway, whereas we wouldn't see that in a normal hospital patient who was admitted with a bacterial infection or had an operation or something like that. So that's probably the other big change I would say that we've had to do in these patients. And that's, again, required a lot of training for the junior doctors to make sure that they understand how to treat these patients. And this is sort of, when you see that positive diagnosis, you treat things differently. And also some of the monitoring has changed as well. So we've done a lot more intense monitoring to make sure, but whereas we normally don't monitor these patients for those treatments, we would in this case, just to make sure it really is working the way we think it should do. So I am actually part of a vaccine trial, which our hospital is running, and most of the hospitals in the UK are trying to do it. It's being led by the University of Oxford. That is where one of our big vaccine research units is in the UK. And it's called the COV, so COV002 research study. That is looking at a vaccination that's based on a sort of a modified rhinovirus, so a cold virus that infects chimpanzees, which started probably about the start of June, maybe a little bit earlier, which was initially looking at sort of healthy volunteers to gauge their immune response. There are a couple of other vaccine studies going on, but that is the main one that's happening in the UK. And the idea of that is it will go on over a year, and you have sort of monthly, or sort of, I think it's monthly initially, and then it will go to 2 monthly and 6 monthly antibody titer levels taken to see, are you developing an immune response? And I think that's the first step, is just working out, is it actually an immunogenic vaccine? Does it elicit an immune response? And actually this week, the first set of trial results have been published in the Lancet, which suggest it does develop an immune response. Whether that obviously will translate clinically into anything at all, we don't know yet. But I think it's recruited over 10,000 people so far. And again, it's unusually, it's a study in which there's no remuneration for it. So you don't get paid for contributing in the study, which most clinical trials you would do. And again, I think it feeds into what you said about the sort of the national effort, and people recognize that this is so important to try and achieve something for this sort of the population, to help get us back to whatever normal might be. The next step, based on the fact that it's been relatively well tolerated, is that now it is going to recruit over 75s. So it will be recruiting people in that population that is potentially at highest risk. And there are talks at the moment about, alongside the national flu vaccination, which is being extended. Normally our flu vaccination is free at the point of access to the high risk groups. The flu vaccination program has been extended to the whole population for this year, because again, if we can minimize flu, that presents in a similar way to COVID, and it just helps manage that. And there's talk, dependent on where we are with the vaccine at that point, that all patients will have a flu vaccine and a COVID vaccine at the same time come the winter months, if we're there at that point, which I think is the overall aim.
Medicamentos que se utilizaron fueron los que las publicaciones de revistas médicas nos daban en su momento. En un principio fue la famosa hidroxicloroquina, Ahora se maneja mucho la dexametasona ya en pacientes que están hospitalizados. Usted si son asintomáticos, el 80% prácticamente pasa fuera de hospitales y el 20% dentro de hospitales. Listo, el manejo de los síntomas, por ejemplo, paracetamol para la fiebre en sí, sí, es verdad, pacientes que son asintomáticos, pacientes que tienen síntomas leves, como fiebre, de forma global, creo que se está manejando el paracetamol. Es muy diferente comparar entre pacientes que están que son pacientes ambulatorios, que llevan su propio tratamiento, que generalmente se les da el tratamiento por parte del centro de salud, o bien pacientes que están dentro de hospitales, se encuentran graves y que a su vez se encuentran graves y que a su vez necesitan más terapia. La investigación en Ecuador es prácticamente nula en la pandemia. El presupuesto ha sido muy bajo, incluso para adquirir medicamentos, cosa que los farmacéuticos estamos teniendo muchos problemas para adquirir medicamentos muy vitales incluso para cirugía. Y no hay presupuesto, no hay inyección de presupuesto, medidas de protección que deben haber, pero muchísimas. Estamos prácticamente cogiendo las últimas raciones para poder protegernos. Y no hay presupuesto para algo tan esencial como esto, para investigación mucho menos. La investigación en Ecuador es 4 veces más cara que investigación en cualquier otro país. Y la investigación acá es nula, es prácticamente nula. No estamos investigando ninguna vacuna, no estamos probando ninguna medicina experimental, no estamos dentro de ningún proyecto de la Organización Mundial de la Salud para probar un medicamento. La investigación para COVID-19 no hay. Muchos colegas que están publicando sus casos clínicos, que son muy valientes, pues cogen y escriben todo esto, lo que ellos han podido controlar a este paciente aplicando esto. Voy a hablar por Perú, 0, Bolivia, 0, hablando con colegas de Paraguay. Paraguay tiene muy controlada la situación por su pequeña población. Brasil está adjudicando, ingresaron vacunas, si no me equivoco, de Oxford para ser probadas, la famosa vacuna de Oxford, que es la gran esperanza, que esperemos esté para final de este año. Ingresó a Brasil y la están probando, pero por iniciativa de la Universidad de Oxford, como pruebas de fase 3, en las cuales las pruebas van a ser para una mayor población. Pero en sí, en el resto de países no lo sé, pero en una gran mayoría pienso que el escenario se repite, excepto por Brasil, que como te digo, es el lugar donde están probando las vacunas, pero por iniciativa de la Universidad de Oxford, más no por iniciativa de su gobierno.
We have something we call isolation centers here in Nigeria. These are centers that are specifically prepared for patients that have been infected with the COVID-19. So when patients are transferred into these isolation centers, different measures of treatment based on the the symptoms they are presenting with, because there's really no cure for COVID-19. We are just trying to see how we can take care of the symptoms the patient is presenting with, from the fever to the maybe increase in temperature, the oxygen level, those are the things we look into basically. And then, at this point, the immune system has to be optimal. The immune system has to be on point. Let me use that word, because this COVID-19 is more like a battle with the immune system, because there's really no cure. We don't know what medication specifically will be able to take care of the virus. So basically, what we do here in Nigeria, we take care of the symptoms the patient presents with, and then find some other things, other medications to also improve or boost the immune system. And then I heard there are some antiviral agents that they use for some patients. Do you understand? And then if the infection is also superimposed with some bacterial infections, some antibiotic will also be administered to the patient. Yes, so basically that's what we do here, since there is no cure. Okay, so presently, it's not just Nigeria, all over the world, everybody's working, trying to find a cure, trying to find if vaccines will be effective, if this particular drug will be effective. So there are some clinical trials that we are currently doing on some of the drugs that have been reported to maybe have a form of, what's it called now? Positive outcome when used. So there are some clinical trials that have been done on chloroquine, dexamethasone presently, and then just recently, the National Agency for Food and Drugs Administration Control, that's like our Drug and Food Act here in Nigeria, they're currently working on an herbal remedy. They're still working on it. Clinical examinations are still going on presently, but no medicine has been said to be a cure yet in Nigeria. So works are still being done on this as we speak.
I think for symptomatic relief, I believe it be basically quite the same worldwide. If they do have chronic diseases, we'll have to ensure their chronic diseases are under control. For more acute cases, if they do meet the criteria, there'll be some, along the ways, the treatment actually, depending on the outcome published as well, by different countries, probably in China, in France, Italy and all that. So initially, we may have patients started on Kaletra, if you know about that. So in terms of pharmacy management, we will have to look at drug interaction as well, because you know that Kaletra is, they do have a CYP enzyme activity that inhibiting some of the sedative, or analgesic that we are using in the hospital, like IV fentanyl. So is there something that, how do we then monitor the IV fentanyl? Or do we switch to IV remifentanil, where there's no interaction? And also some of our patients are actually recruited in the remdesivir trial as well. And you know that now remdesivir probably has gotten the, the so-called conditional approval. And Singapore is one of the countries that actually do get benefit from the donation of Gilead, the pharmaceutical company, on using the remdesivir if our patient do meet the inclusion criteria. Yeah. So there are a lot of legal process as well, to safeguard our patient when we are using these medications.